Welcome, everyone. My name is Dr. Jeffrey Calvert. I am the Associate Director of Clinical Quality at the World Trade Center Health Program, which is a division within NIOSH and CDC. It's my pleasure and honor to introduce this 7th installment of the World Trade Center Health Program's Clinical Best Practices webinar series. Please note that all of our Clinical Best Practices webinars are recorded, and those recordings will and are available on the World Trade Center Health Program website. Currently, the recordings for the first 4 best practices webinars are available. Today's webinar is titled Clinical Best Practices for the Diagnosis and Treatment of Chronic Obstructive Pulmonary Disease, or COPD. It will be presented by a well-regarded pulmonologist who has a long-standing affiliation with the World Trade Center Health Program. He is Dr. Rafael De La Hoz, pulmonologist, occupational medicine specialist, internist, and professor at the Icahn School of Medicine at Mount Sinai. And I'd also like to introduce my 2 NIOSH colleagues who are kindly assisting with today's webinar. First is Kiana Harper, who's responsible for the technical aspects of the Zoom webinar, and also Ann Riddle, who's assisting with the slides and will be reading the questions and comments that you submit. So disclaimer, the views expressed in this presentation are those of the speaker and do not necessarily represent the official position of NIOSH or CDC. Mention of any trade names, commercial practices, or organizations does not imply CDC or NIOSH endorsement. And finally, any citations to websites external to CDC NIOSH do not constitute their endorsement of the sponsoring organization or their programs or products. And CDC NIOSH is not responsible for the content of those websites. And we have one disclosure from Dr. De La Hoz, who reports that within the past 24 months, he's attended promotional programs hosted by AstraZeneca and GlaxoSmithKline, and also received a lecture honorarium from Teva Denmark. All of these financial relationships have been mitigated. And without further ado, I present Dr. De La Hoz, who will now present on diagnosis and treatment of COPD. Take it away, Dr. De La Hoz.
Thank you for that introduction and for inviting me to present on the best practices for the diagnosis and treatment of COPD, and which was published as part of a series on these reviews in this publication, which is available in public access, open access. Practically all the references that I cite have the PubMed ID, and practically all of them are open access unless I made a note to the contrary. So I just wanted to mention that for those listening, that perhaps that's just the most this easiest way to annotate any particular reference. And most of the reference that I am presenting are already in this article. So there are very few that are not, and I may mention some of them. I wanted to make sure that you all knew that in this effort, the lead author and co-author was Dr. James Cohn. He is the medical director of the World Trade Center Registry of the New York City Department of Health and Mental Hygiene. And so this was an important effort on his part to spearhead, and any errors in the presentation are all mine. He's not responsible. So in terms of other acknowledgements of, I do receive grants as principal investigator in NIOSH World Trade Center research in the first 2, and co-investigator in the other 3, and some salary support for some clinical and administrative work that I do for the World Trade Center Health Program. And the disclosure still applies as described by Dr. Calvert. I wanted to also indicate that at the start of this project, we selected as a guideline the dose of the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, COPD, the 2021 guideline, which is a fairly large document, and we just summarized it in this article. Those guidelines are freely available on the internet. This is the site, goldcopd.org. And the reason they were selected was because they were consistent with current certification guidelines for COPD in the World Trade Center Health Program, and sound, have a wide application, are very widely accepted. And also they are consistent with the current medical coverage guidelines of the health program. So the article itself was very short. We were instructed to keep it to about 2 pages and 10 to 20 references, and so did we. So just jumping right in, we'll start with the definition of the disease. COPD is a preventable and treatable disease state characterized by airflow limitation that is not fully reversible. And that airflow limitation is usually progressive and associated with an abnormal inflammatory response of the lungs to noxious particles or gases. But the primary cause in terms of frequency, of course, remains cigarette smoking. Although primarily affecting the lungs, COPD also produces significant systemic consequences, and I'll refer to that later. So one issue in terms of this definition and terminology that I wanted to impress upon those listening to me, particularly those who have a longer trajectory in medicine, is that COPD is a term that encompasses 3 features that in and of itself do not constitute or do not define COPD, but that are mixed together, and they are identifiable in virtually all patients with COPD. The first one is chronic bronchitis, which has a symptom definition is chronic or recurrent productive cough on most days for a minimum of 3 months per year and at least for 2 consecutive years. So you see, it's an epidemiological, clinical, subjective definition, and it is thought that chronic bronchitis primarily affects the proximal airways, the larger airways. A small airway disease is mostly a pathological definition, histopathological, and is characterized by inflammatory changes in the distal airways. And the operational definition of that for pathologies is that, and that has a functional correlate, is that the small airways are those that have less than 2 millimeters internal diameter, and also small airways disease leads to increased resistance to airflow. And finally, going further distally into the alveoli, we have emphysema. And emphysema is defined by permanent and destructive enlargement of the air spaces distal to the terminal bronchioles, and those are mostly alveolar ducts, respiratory bronchioles, and alveoli themselves, without obvious fibrosis. That's the classic definition. It's a histopathology definition, and I emphasize none of these 3 define COPD, but on the other hand, most COPD patients have a mixture of these 3 elements. And that is, whenever you see a diagnosis of chronic bronchitis or emphysema, that's not necessarily a diagnosis of COPD. That's an important message. Further to that, GOLD guidelines define COPD as the presence of fixed airway airflow obstruction. And that is right here, is post-bronchodilator, ratio of FEV1 or forced expiratory volume in the first second, and forced vital capacity less than 0.7. I will be using this throughout the many of the slides. So This is the definition of fixed airflow obstruction. Airflow obstruction is reduced FEV1 over FVC, but if it is after bronchodilator, that's why it's called fixed. Long-term patients with asthma and some other pulmonary diseases can often demonstrate, meet this criterion. They exhibit fixed airflow obstruction. So that's one of the problems with it, and I wanted to mention right away that this definition is by no ways perfect, but in fact revolutionized identification of COPD throughout the world, because this is very difficult, very easy to calculate. You just need a regular calculator and you extract this ratio. So even in resource poor environments, it was easy to diagnose COPD with very low technological requirements. So just so we understand the pathogenesis of COPD, as with asthma, is very similar. I have a similar slide for asthma, but we have the conjugation of environmental factors that, first and foremost is tobacco, but of course infections, occupational and environmental exposures. And there are a number of host factors. We know that some people are susceptible, and that's probably genetically determined. And then the conjugation of those factors lead to inflammation. So COPD is an inflammatory disease, and is probably a number of pathways are involved, very complex, and involve oxidative stress, protease, anti-protease imbalance, and also a variety of neutrophil, macrophage, and T lymphocyte mechanisms, mediated mechanisms. And that leads to a variety of structural changes that I essentially alluded a little bit with my previous listing of the main components of COPD. And going from the more distal to the proximal is alveolar destruction, which is what we call emphysema, distal airway dilatation and inflammation, which is what I call a small airways disease, and bronchial gland hypertrophy, which is most notable in the proximal airways, and that's what is the basis for chronic bronchitis. So they lead to functional changes that I have mentioned: airflow limitation with only partial or no reversibility upon administration of bronchodilator, bronchial hyperreactivity. Realize that individuals with COPD have often bronchodilator response or methacholine positivity, but that doesn't define the disease necessarily. And the other changes are gas trapping, which is an increase in residual volume. That's the technical definition for pulmonologists. And overinflation, which is increased total lung capacity. Again, that's a definition that pulmonologists should have very clear. And decreased diffusion capacity with an impairment in the transfer of gases across the alveolar capillary membrane in the lung. So that, of course, conjugation again of structural changes and functional changes lead to the symptoms that we identify for the disease. Realize that asthma, COPD, and all other airway diseases result from essentially a conjugation of a number of factors in the environment. I mentioned environmental, occupational, that lead to bronchial inflammation, and that somehow lead to different phenotypes that we try to recognize or define clinically. And that's where sometimes the controversy comes from as to what is one and the other, how far does one go into the other. And but just realize that pulmonologists sometimes, if you notice that your local pulmonologist has a difficulty differentiating in an individual patient asthma from COPD, well, there is a reason for that. And sometimes more detailed observation of the patient, additional testing and all of that may be required to really differentiate. I already alluded, this is to the human airway morphology when I described the above. Maybe I should have put this early on, but we understand, as you know, the airway tree proceeds from the trachea down to the alveoli by bifurcation. it is a perfectly bifurcation system. And there are about 23 generations of bronchial branches, and the acinus of the lung is defined as the unit distal to the terminal bronchioles. So, and that has respiratory bronchioles, alveolar ducts, and the alveoli. And one of the differences between respiratory bronchioles and terminal bronchioles, for those who may not remember that, is that the respiratory bronchioles start having budding alveolar units, whereas the terminal bronchioles are strictly conductive. They don't have gas exchange units, which are the alveoli. So that's the difference between the two. So just for reminders. So when we talk about distal airway disease, we are usually referring to terminal bronchioles and respiratory bronchioles. All right, so again, in pathology, just to quickly illustrate, the proximal airway changes in COPD. This corresponds mostly to chronic bronchitis, although I said chronic bronchitis is a symptom definition and an epidemiological case definition, but it has this correlate that the submucosal glands in the proximal airways are very heavily hyperplastic, and there are inflammatory infiltration of those glandular tissues. So that's what probably is thought to lead to the symptom of chronic cough. When we go more distally to the peripheral airways, the bronchioles, this is a terminal bronchiole. You see that doesn't have a budding alveoli. And you see that these bronchioles have these alveolar walls that kind of tether it. And it is when emphysema happens that these alveolar wall tethering of the terminal bronchioles collapses, and they eventually, you see them here disrupted, right? So it loses attachments, and because it doesn't have cartilage, it's not a rigid structure, it becomes distorted. And on top of that, there is an element of fibrosis and inflammation of the wall of these bronchioles that leads to what we understand and recognize as a small airways disease. And going more distally, we go to the alveoli, and that's where we find the emphysema. And emphysema is also another term that we have to be careful. Pathologists describe different types of emphysema. Not all emphysema is the same. And the one that we are referring to for the most part in COPD and tobacco smoking is centrilobular emphysema. And what happens is that if you look, with low magnification, and this is just a diagram for that very illustrated one, that you see that the dilatation of the airway spaces is mostly in the central part of the acinus. So because that's where the small airways are affected and most of the damage occurs. Of course, if the disease is severe enough, it will expand, but it does so centrifugally. So it does go from the center of the acinus towards the periphery. But this is what is called centrilobular emphysema, and this is the most classic association with cigarette smoking. In contrast, we have panacinar emphysema. Panacinar emphysema means that the entire acinus is affected more or less in a similar manner. So you see how it's fairly homogeneously distributed throughout, and this is classically associated with alpha-1 antitrypsin deficiency. Now, I need to say that most individuals with alpha-1 antitrypsin that develop emphysema tend to be smokers. So it's not completely independent from smoking. It's just that alpha-1 antitrypsin is the substrate and upon which cigarette smoking enhances the destruction of the alveolar walls. But it happens in these fairly homogeneous distribution throughout the pulmonary acinus. And I wanted to mention to many of the non-pulmonologists that there is a third class of emphysema, and I get this question at least once every 2 weeks. I have this patient with emphysema, and he wants certification. First of all, emphysema is not COPD by itself. And second, you have to look at what type of emphysema we are talking about. And paraseptal emphysema is thought to result from early life insults like infections or developmental issues. It tends to cluster in the around the septa. So you see it here. This diagram is kind of easier to look at it, and subplurally. Okay, so it's completely different from the other two that I mentioned. In a CT scan, you just have to watch for that, you know, that subpleural and paraseptal distribution. And this is not necessarily associated with smoking. And by the way, it is thought to underlie some of the cases of spontaneous pneumothoraces that we see. So this is important to identify, for example, for divers, because these may be a predisposing factor for spontaneous pneumothorax. But this is not hardly ever COPD unless the person is a heavy smoker. So in which case, probably that person also has centrilobular emphysema. So, but paraseptal emphysema in and of itself is definitely not the emphysema that we associate with COPD. So anyways, the other component that is is important to recognize, particularly when we follow these patients, is that there are pulmonary vascular changes that are very important. It is thought to happen. This diagram illustrates that perhaps because of chronic hypoxia, there's pulmonary vasoconstriction, pulmonary hypertension, with changes in the structure of the vascular system in the lung, muscularization of the vascular wall, hyperplasia, fibrosis, and eventually even obliteration of the blood vessels. That eventually increases the resistance, leads to cor pulmonale and peripheral edema, and it is a strong contributor to death in these individuals. So that is this is an example of the destruction of the pulmonary capillary bed that is observed in individuals with COPD, and where you see the extensive changes in the vascular, the capillary walls, with this intimal proliferation in the muscular development or hyperplasia, and the obliteration of the lumen of the capillaries. And in this article, this is not cited in, I think, in the best practice article, but it's available in the American Journal of Respiratory Critical Care Medicine. We see here a non-smoker without emphysema and without COPD, and here goal for severe COPD individual. And you see here the vascular tree as assessed by quantitative CT, and you see how there's this pruning of the vascular circulation that increases resistance and eventually leads to cor pulmonale. So this is an illustration by imaging of that process. Anyways, radiology tends to, and imaging, chest imaging tends to give us a little bit of a picture. I was relying up to now on micrograph, but you know, we mostly have is X-rays and chest CTs. And classically, the chest radiograph shows these areas of hyperinflation with the classic flattening of the diaphragm, hemodiaphragms. You see them almost convex instead of the concavity that you expect in a normal CAT scan. And these are usually areas of confluent emphysema with formation of bullous disease. Those large airfield structures in the lung that do not exchange oxygen. So of course, CAT scan is gives us a two-dimensional view of that, and you see here the areas. This is you know, you don't see it well. This is an area of emphysema. these. And you see it because the structures of the lung get kind of, separated, so it's splayed. And so there are all of these areas of emphysema. This is a classic case of centrilobular emphysema. Sometimes you do the CT scan and exhalation. The normal lung increases in density, and then you can highlight the areas of emphysema that are not moving air anywhere. This is literally trapped gas, and that's what emphysema is, and is often seen in COPD patients. Notice also that the wall of the bronchial tubes tends to be thickened. It tends to, and sometimes they get plugged also. So you can see that in chronic bronchitis and chronic bronchiolitis. This is another example of very severe COPD emphysema in a COPD patient. So from imaging, we can move to lung function, and many in the audience are, if not from their clinical practice, from their medical school, they are taught about the spirometry and the two types of tracings that we utilize, the volume time curve and the flow volume curve, that is defined by the ordinate in this graph is the expired volume, and here's the time during the fourth exhalatory maneuver, and the flow volume curve is here, is flow instead of volume, and then volume comes here to the ordinate, to the upside side. So a COPD individual has this flattened, in terms of the hyperbolic shape of the normal individual, has this flattened because the flow is limited, particularly in the early part, starting from the early part of the exhalation. And in the flow volume curve, the representation of that is that the peak flow is not reached, right? That would be predicted for this normal individual. And also that is, there's a precipitous reduction in the flow towards the end of the exhalation. So it's like they are blowing, exhaling through a straw. That's literally definition, and that's many times how the patients feel. So good quality pre and post bronchodilator spirometry is required to make an accurate diagnosis. And the revised American Thoracic Society 2019 guidelines define that as having a volume at the end of the test of 25 mLs or so. So this is a very tiny amount. So that implies that just keeping the fourth exhalation is not going to change the results significantly. They also indicated that having an individual exhale for longer than 15 seconds again has very little diagnostic yield. So if the individual still feels like he can continue exhaling, so they are starting to look purple, don't go past 15 seconds. Or the other criterion, which is a little bit more difficult, because you have to see the graph, the volume time graph while you are performing the test, and very few people have that privilege except in laboratories, that this curve here is becoming flat. And that is the other, these are the three criteria for end of test. And again, fixed obstruction is defined by a post bronchodilator ratio of FEV1 of FVC less than 0.7. Now, just to introduce the controversy, and also because you will see it in many pulmonary laboratory reports, the other way to assess this is by using the lower limit of normal by the 5th percentile, which is in itself a little bit arbitrary itself. But the big controversy amongst pulmonologists is which one to use. For the purpose of the GOLD guidelines and for the best practice of the health program, we utilize the 0.7 ratio as the threshold. Just to go over why do we worry about COPD, because it produces accelerated decline of lung function over the lifetime of the individual, to the point that symptoms start appearing, disability starts appearing, or earlier death happens. So we have, however, non-smokers or non-smokers who are non-susceptible, that they are always known to exist, that this is the normal decline decline with age, which should not lead really to significant symptoms even in very advanced age. So this is a susceptible smoker that develops COPD. Now, just to, this was from the classic a publication from Fletcher and Pito in 1977, smoking cessation tends to return individuals to a normal rate of decline, but of course it happens after an accelerated period, and so symptoms and disability may occur. And the earlier an individual stops smoking, it pays a dividend in terms of preserving lung function as they advance in age. So that's what this illustrates. This is the classic thing, but it turns out that in this publication from 2015, it was realized that the individuals that we identify as having COPD includes a proportion of subjects that never reach during their development and youth their total potential of lung function development, and that in fact they may be declining at the rate that is similar or exactly the same as those of individuals without COPD. So this has introduced some complexities to, and it underscores the importance of following these individuals, not only to diagnose COPD, which both of these trajectories have, 3 and 4, but also to see what the rate of decline is. And our health program is very well suited to actually do that. Illustrated some of the investigations that have been done with these longitudinal trajectories. Here is a group of about 1,300 World Trade Center individuals who have had chest CT scans, that they are part of a cohort that I follow. And as is well known, the rate of decline of lung function of FEV1 in this case in World Trade Center cohort members, this is an occupational cohort, general responders, but the fire department publishes exactly the same, follows about in this green trajectory. The vast majority of people are there in that trajectory, in the green one, with a normal expected age-related decline in FEV1. However, we know that there are subsets of individuals who are declining way faster. And those are the ones that worry us. And several of them are individuals who have markers of emphysema and of COPD, and that are the target of many efforts to try to curb this decline. An interesting point that I'm not going to belabor is that some of them seem to be improving, which is not normal in individuals who at this point in time were aged about 40 years. Individuals with 40 years of age usually do not increase lung function. And we think that these are people who may have recovered lung function after the 9/11 related exposure. But I won't belabor that point, just to mention to those of you who may have noticed that trajectory in particular. Now, going back to the environmental and occupational exposures that are recognized as causally related to COPD, cigarette smoking, occupational dust and chemicals, environmental tobacco smoke, indoor and outdoor air pollution. There are extensive publications on all of them. And I'm going to mention some of the publications that have studied the association with COPD with World Trade Center occupational exposures in this particular example that I'm going to mention. And this was a study from the Fire Department of New York, and they had 2,000 out of a cohort of close to 10,000 individuals who had undergone complete pulmonary function testing with the required post-bronchodilator spirometric testing. But that testing was done upon clinical indication, not to everybody. So they identified 314 subjects, which constitute about 3% of the entire cohort. If you think of, that this would be the denominator, but 14.7 of these 2,100. and 4.6% had the standard definition of bronchodilator response. And they, in their study, they defined that as asthma and COPD. Disagreement that I have with that is that many COPD patients, it is 30 to 60%, depending on the study, have bronchodilator response by the standard definition. So in their study, neither COPD nor ACO, as defined here, were significantly associated with higher World Trade Center related exposures. Now, this study was from the World Trade Center Health Registry of the Department of Health here in New York City. That study, that registry includes about 14,000 rescue and recovery workers. And these are the percentages of self-reported physician diagnosis of COPD and asthma COPD, respectively. And I'm a co-author in this article. We described how several indicators of heavier occupational exposure were associated with COPD and with asthma COPD, and a longer duration of at the World Trade Center pile was also seemed to have a trend towards increasing association. So, but this was only for ACO. So you see a little bit of the disagreement with the previous one. And then we go to the third publication later also in time. And I collaborated with the data center, general responders cohort general data center. We had 18,000 individuals from the Mount Sinai clinical center that had acceptable quality spirometry. And that was another thing that we were very stringent of what, and we define and publish exactly what criteria we use to consider a spirometry acceptable. And we discarded everything else. And we had to discard thousands of spirometries, by the way. So anyways, out of those 18,000 individuals, we identified about 500 with COPD by the definition of the post-bronchodilator FEV1 FVC ratio less than 0.7. And for our case definition for asthma COPD overlap, we require a large not the standard, a large bronchodilator response exceeding 400 mLs, and at least 12%, of course, of the pre-bronchodilator measurement. And it turns out that almost half of them met that criteria, had that. And most of the cases were mild to moderate. You can see here the percentages. Almost 1 in 4 were mild, and 60% moderate. So only 10% were severe or less severe. So also we couldn't help noticing that the rates of current smoking, cigarette smoking prevalence decreased linearly from 2003, when it was about 19.3% to 5.6% in June of 2019, which was for this particular publication, the last time that we had available. And I realized that this was just pre-COVID, so spirometry stopped being performed temporarily. And we noticed an association weak, but statistically significant for both our case definition of COPD and of asthma COPD. Here are the odds ratios and their confidence intervals. By the way, we took those that had self-reported physician diagnosis of COPD and asthma, people who said that they had, a doctor had told them. And it turned out that there were 4 times more people reporting this diagnosis, and yet there was no association with the occupational exposures when it was defined in that manner. Gold says that we should proceed from a spirometrically confirmed diagnosis using the criterion that I have mentioned, and I will continue mentioning, and then classify the severity of the disease by the post-bronchodilator FEV1 in the percentage, the percent predicted, and here are the percentages. So again, just to reiterate, most of the World Trade Center, 90% of them cases are goal 1 or 2. So they have at least 50% of post-bronchodilator FEV1, and then classify them depending on the severity of symptoms using these standardized questionnaires, the MRC or Medical Research Council or the CAD, and the exacerbations into these 4 groups. They are now changing that, and they want to collapse these 2 groups, C and D, into E, exacerbators. So I just warn you that these things keep changing, and there are suggested treatments in this table, depending on those 4 categories, at least for initial treatment. And I just wanted to point out to the fact that inhaled corticosteroids are usually reserved to group D, so people who exacerbate relatively frequently, more than 2 moderate exacerbations per year, and are highly symptomatic. There's quite a bit of dyspnea, and that have peripheral blood eosinophil counts exceed of 300 or more. So that's where inhaled corticosteroids have their best indication. Notice that in the other 3 groups, ICS are not really recommended unless you have some particular reason to do so, but in general, it's not recommended. So here are how exacerbations are defined, and this is still being worked on. I won't belabor this point because in the interest of time, but see how the definitions are dependent on what type of treatment, from the bronchodilators, inhaled bronchodilators, all the way to hospital admission or emergency room treatment. So see what the time had, and so the best practice is it's assessment of history, risk factors, symptoms, including their intensity, history of exacerbations. Obtain all of these descriptors because you see how they factor on how we manage these patients. Proceed to the spirometric diagnosis of fixed obstruction. And it should be preferably done on at least 2 different occasions, ideally after treatment implementation, and always based on good quality spirometry with bronchodilator testing. And additional functional imaging evaluation is often recommended for further characterization, differential diagnosis, or for the assessment of and/or exclusion of comorbidities. But in terms of the diagnosis of COPD, the 2 mainstays of the diagnosis are these: the assessment of symptoms and risk factors, etc., and the spirometric definition. So I mentioned already the grades 1 to 4 of based on post-bronchodilator FEV1, the classification based on symptoms and exacerbation, the assessment of comorbidities, and but it is important because you know, to assess impairment and disability, and also you know, that in the occupational setting we have some surveillance reporting obligations. So the process goes again from this basic assessment, and then initial management, and then upon you know, subsequent visits, you reassess pretty much the same elements. You go over the symptoms, you go over the exacerbations, you see what the smoking status is, what other risk factors and exposures the individual has, what is the how good is the inhaler technique and adherence, physical activity, etc. I won't belabor that, it's in that graph. And then you adjust the pharmacotherapy and the non-pharmacological treatment, and you essentially repeat this process through subsequent visits and retest as needed. At least annual spirometry is recommended in the follow-up of individuals diagnosed with COPD. The treatment of COPD, very quickly summarized here: smoking cessation, curtailment of hazardous occupational environmental exposures, infection prevention, appropriate vaccinations, healthy lifestyles, and weight management, the implementation of stepwise treatment, treatment and or prevention of disease worsening comorbidities, supplemental oxygen, pulmonary rehabilitation is often beneficial to these individuals and is grossly underutilized, I will remark. And in selected cases, then you proceed to with usually very severe COPD, consideration by for lung volume reduction surgery, valvectomy, bronchoscopic valves and coils that usually requires a pulmonologist evaluation, and realize that 1/3 of all lung transplantations in the United States are done on severe COPD cases. So this is a frequent cause of a transplant in the United States. It is a very disabling disease, just to reiterate. Patients with asthma, GOLD advises to treat the asthma component first with whatever is appropriate for the management of those individuals. And if you have individuals that have chronic non-specific or non-obstructive bronchitis or low FVC, which is very common, it's the most common abnormal spirometric pattern in the Walter Center cohort, you essentially rely a little bit like with the ACO, with inhaled corticosteroids and bronchodilators, because right now there are no clinical trials. They are ongoing. The first clinical trial was published and it failed. So we don't have clear guidelines as to how best to treat these individuals, but it makes sense to treat them, as I described before. Lots of controversies. Is a very lively topic. GOLD meets every year and arguments go back and forth. How to define fixed obstruction? I already mentioned the fixed criterion 0.7 versus the lower limit of normal. What to make out of asthma and COPD overlap, and is that really a syndrome? The syndrome disappear from that. I don't know if I'll get to mention that. What to do with chronic non-specific or non-obstructive bronchitis, and the issue with the low FVC, individuals that have low FVC. So the controversy about diagnosis is, of course, that if you have here the post-bronchodilator FEV1 FVC ratio, and over time, GOLD says that for everybody, no matter the age, you should use a fixed ratio of 0.7, and the people that have more than 0.7 and non-obstructed, and the less is obstructed. But if you use lower limit of normal, it turns out that the line is like this, because it turns out that FEV1 FVC also declines with age. The ratio is really not fixed from youth to old age. So that is where the problem comes up. And that happens at about age 60, 65. Dr. Aaron the other day said that it was about 70. It varies according between 60 and 70. It starts happening that these two lines cross, and that's what introduces discordant diagnosis. People who are COPD by one criterion and not the other. We don't have a problem with those who are non-obstructed by both or obstructed by both, but the problem is the discordance, which tends to happen as disease advances. Here it happens, but it's not a problem, not so much a problem. But here it is a problem. So that's where the controversy comes from. And the other one is that there's what is called diagnostic instability, that there are individuals that if you follow them over time, they may show the COPD here, but then they revert and then they come back. It's, that's what they call diagnostic instability. Dr. Aaron's the leader on that. He just presented a grand rounds to Mount Sinai the other day that we are still remembering many days later. And in two large cohorts, they could see that diagnostic instability in a substantial percentage of individuals. And they could see that 1 in 8 to 1 in 4 subjects with mild to moderate COPD, so that's why it's important to classify these subjects, revert their diagnosis with over 4 to 5 years, apparently revert. And this is the fact that as long as we use a fixed line, we are dividing the world in black and white, and it turns out that biology and medicine seldom are like that. So they also determined that there were usually an FEV1 of FFC less than 0.65 and not 0.70 tended to give more stability. Those individuals upon follow-up very rarely reverted. So I'll just leave that with that. It's not part of the guideline, but just so you see some of the things that come up. So this diagram from the same group, the Dr. Aaron in Ottawa, show that you have to have symptoms in the individuals. Usually they have to be some type of exposures, usually more than 40 years of age. If somebody meets the criterion is defining COPD, treat as such, but realize that you need to test for diagnostic instability, particularly if the case is mild to moderate. If you don't have that ratio, but there is broncholateral response, maybe you want to treat for asthma. If you don't find obstruction, you really have to rethink your diagnosis, work up the individual for other causes of these symptoms, of dyspnea, cough, or whatever it is. And it's an alternate diagnosis is reached, treat as appropriate. But let's see you don't get an alternate diagnosis and you keep thinking that it could be COPD, well, repeat the testing. And if you get your diagnosis, you repeat it, you treat accordingly, but keep repeating the testing because it could be an unstable diagnosis. Again, for the case for asthma, where the ratio is more than 0.7, but there's bronchodilator response, you might treat for asthma. And if you have no airflow obstruction in spirometry, really consider methacholine challenge because maybe you have a case of asthma, or a chest CT to include other diseases like interstitial lung diseases or bronchiectasis that can easily give you this diagnosis. So that's just a suggested thing. Asthma, COPD, the controversy is that there are different pathways by which individuals can have the two diseases. So that's why it's so controversial. So I don't know, and if I have time for my case presentations, but or I can go to my conclusions. Where am I? Ooh, I think I should go to my conclusions. Sorry about that, but we had some, oops, sorry. So those are the 4 cases that I have. I just wanted to make sure that it leave you with the impression. Prevalence of COPD in the World Trade Center, at least the occupational cohorts, is generally low compared to enhanced to national surveys. Is the effect of the cohort age and also very effective smoking cessation efforts that have been extremely effective. There is some evidence of association with World Trade Center exposure with COPD is weak and is not consistent across cohorts. There is some suggestion about 50% of all World Trade Center health program COPD cases had asthma that it probably evolved into fixed obstruction. So this is a problem that we have with our COPD case, and that's why we need to continue observing these cases for diagnostic instability. About a third of COPD cases in the World Trade Center health program claim to be lifetime non-smokers. So that's important. Don't exclude the disease in somebody who is a non-smoker. That's even more pronounced in the fire department cohort. And 90% of the COPD cases in the World Trade Center are mild to moderate, so more prone to this diagnostic instability that I described before. And that another take-home message, World Trade Center COPD cases should have repeated pre and post broncholateral spirometry to assess for the longitudinal trajectory. Number one, I told you it could be completely normal, or because of diagnostic instability. Our program is very well suited to do that. And I wanted to, final non-pulmonologists have an extremely important role to play in the care of COPD patients. If the care of these patients depended on pulmonologists, these patients would have no hope because there are not enough pulmonologists around and the availability is not quite what it should be. So the non-pulmonologists have a very important role to play, and I wanted to impress upon many of you that factor, that early detection, because we contribute to that with good quality pre and post bronchodilator spirometry, assessment of diagnosis stability with the same good quality spirometry, infection prevention, including vaccinations, smoking cessation, diet improvement, weight management, curtailment of exposures that may aggravate the disease, identification and prompt and adequate treatment of comorbidities, particularly heart disease, pulmonary rehabilitation, extremely underutilized. Not that it is easy to get, not that it is easy to find, but grossly underutilized, and assessment of oxygen needs. And I will leave it with that. Sorry to have exceeded the ideal time, but I'll be happy to take some questions. And again, on behalf of my co-author, these are our addresses, and please send questions and concerns, comments to us.
So thank you, Dr. De La Hoz.
So stop sharing. Sorry.
Yeah, please stop sharing.
Yeah,
and we'll let me talk about the continuing education credits, and then if we have time after I finish, there are some questions, and we'll hopefully try to get to at least one of them. So for continuing education, I recommend that you take a screenshot of this slide so you have the web address and the information you'll need to find the course. So to get the continuing education credits, log into the CDC train system. I've got the website here. Then you'll need to find the course, which you could search. The easiest thing would be to search by the WC 4740. You could also search by WC 4740 and include today's date, which is, actually, I've got the wrong date there. It should be 03/14/24. But you'll be able to find it with WC 4740. And then they're going to ask you for an access code, which is WTC HP. And if you're viewing the recording of this webinar, you'll find the course by searching for WD, not WC, WD 4740. And then after you've registered for the course, you'll check the box for the type of CE that you would like. Then you complete the course, which you did here. And then once, if there's a mark completed button on the train page, click that to move to the next step, which is to take the post test. You'll have 2 attempts to pass that post test. There's 4 questions. You need to get at least 3 of them correct. And then you'll need to complete the evaluation. So for the live course, you can get these CE credits. They're available for the next 30 days. So until the middle of April. And then if you watch the recording, those are available for at least 2 years, and we'll probably renew it. So you'll have a total of 4 years to get the CE credits for the recording. So that's that. And we have actually a couple of minutes. So, Anne, do you want to go ahead and, oh yeah, thank you. Let me just quickly announce our next webinar is next week on the 21st. We'll be talking about managing depression and suicide risk. It's going to be given by Dr. Lowe, who is with also with Mount Sinai in New York City. And so we still have a couple of minutes. So Anne, why don't you go ahead and ask the first question for Dr. De La Hoz. Thank you.
All right, I was on mute. Thank you, Dr. Calvert, and thank you, Dr. De La Hoz, for your presentation. We got a couple questions related to the GOLD 2021 clinical practice guidelines that you mentioned in the webinar. So kind of a combination of them. Why didn't, is there a reason that you did not discuss the 2024 or the 2023 COPD guidelines from GOLD? Are you aware of any substantial differences between the 2021 and the 2024 GOLD version?
The more recent version, the reason I alluded to the 2021, it was because when we wrote the article and this effort for the best practices started, really those were the guidelines, the most recent that we had available. So that is a historical thing. And the GOLD committee is very vibrant. And I was mentioning how many controversies that are flying around, and they meet yearly in November. So the more recent changes have had to do with really acknowledging certain mitigating circumstances or to certain definitions. So for example, the prism or low FVC pattern that we see in the World Trade Center, you know, there is increased awareness. It doesn't make it to a definition of COPD, but it may require treatment. And also it is known that a proportion of those individuals, particularly smokers, may evolve into COPD. Other things, category C and D, in other words,
So
people
Dr.
who
De La Hoz, we're going to have to cut you off there. So
Okay.
it's 1 o'clock.
Send your questions to Anne, and I promise that I will answer them
Thank you
after.
so much for that
Sure.
very interesting presentation. And thank you everybody for attending. And we'll see you hopefully next week. Take care. Bye.